Hi, Professor. Today we'll be talking about my case study. This is a 67-year-old white female who presents an urgent care complaint of abdominal pain. She also reports vomiting, constipation, and absence of flatus. She further reports having a past medical history of intermittent abdominal pain, accompanied by bloating over the past 3 months. The patient claimed the pain usually starts at the right upper quadrant and radiates through her abdomen. Abdominal distension was also noted. Characterized by rounded asymmetrical contour, bowel sounds at this time is hypoactive. She is not on any medications, prescribed medications, but is taking herbal supplements and some vitamins. Pain qualifiers are the PQRST mnemonic. For palliative, she states the pain started less than 72 hours ago and is aggravated by extending to the right lower extremity or on coughing, and the patient gets better with gentle massage. Quality is some cramping, right upper quadrant. Severity of the pain is 8 out of 10. Timing, movements of the right leg or when she coughs. Understand the patient thinks the abdominal surgery she had a year ago could be responsible for the present symptoms. Past medical history for the patient. She has had some immunizations, including TB and polio. She has had other health issues that do not necessitate hospital admission, such as cough, colds, fever, sore throat, rash, and diarrhea. Surgical history for her 12 months ago. Patient had an exploratory lap. Um, the surgeon discovered a mass in the descending colon, and the tumor was removed, and biopsy was also done at that time. Review of symptoms is non-contributory as most of it's negative except for GI issues. Diagnostic tests and differential diagnosis include small bowel obstruction, which was confirmed. Appendicitis and diverticulitis were ruled out. Plan of care for the patient at this time: administration of IV fluids, bowel rest, nothing to eat at this time. Patient will be taking gastrogafin challenge to predict whether the obstruction will resolve itself. After 48 hours, which is, of course, is non-operative management. During this time, we will actually observe the patient. If the situation, we do recommend the patient to go to the emergency room for further evaluation and recommendation. Medications right now is an antiemetic like NMED 80 milligrams pure twice a day and analgesics like Tylenol as needed. If no improvement, um, for the emergency room, the patient might get a nasogastric tube as well as possible operation to actually help with this issue going on. Referral to possible oncologist if the situation doesn't get any better. Patient needs to follow up with primary care physician or returns to the clinic in another 14 days.